All right. Now it's time to talk about devices and electrodes and contraindications, precautions, and indications for electrical stim. So in this section, the learning objectives are to state the general indications, contraindications, and precautions, talk about electrodes and skin prep and how it affects treatment, the size, condition, and placement of the electrodes, and how does electrode placement affect the depth of the treatment, and monopolar, bipolar, and quadrupolar electrode setups. So you could probably figure it out. Monopolar's one, bipolar's two, quadrupolar's four. We'll set them all up. So, general contraindications and precautions. If someone has a pacemaker or really any other implanted device, don't use electrical stim. You don't want to mess up their device. An implanted cardiac defibrillator, yeah, that seems like a contraindication. Unstable arrhythmia, electricity, arrhythmia, don't go together. Over the carotid sinus, I don't know why you would do that, but don't. Contraindicated. Over venous arterial thrombosis. So if you have blood clots, you don't want that. If somebody's pregnant, don't use it on them. Precautions, cardiac disease. So any kind of cardiac disease, because as we probably, hopefully recall from pathophysiology, a lot of the cardiac diagnoses kind of affect each other. And so if they have any kind of cardiac disease, it's a precaution. It's not an absolute contraindication, but you want to be cautious. Impaired sensation or mentation, that makes sense. Especially if you're doing a sensory application or even a motor application, you have impaired sensation, they're not going to be able to give you adequate feedback for you to get a good treatment. Malignancy, it's a precaution for just about everything. Skin irritation and open wound. If you put an electrode over skin irritation or an open wound, it could um, irritate the area, and you don't want to do that. There are some wound care applications that use electrical currents, and we're not going to be doing them, but not in lab. But that's, so it's a precaution. It's not a contraindication, and usually it's a specific application you use for that. So the potential adverse effects, you could burn people with electrodes. And we'll talk about the current density and how that's affected. A lot of times when you get burns, it's where somebody had an open wound or skin irritation to begin with, and that's why it's a precaution. Um, just skin irritation in general or pain, if the actual application of electrical stim is increasing their pain, well, we don't necessarily want to do it. Although I've got to say, muscle stim isn't comfortable. I don't know if it's painful per se. That's everybody's individual perception, but it's not comfortable, that's for sure. We'll find that out in lab. So there are all sorts of different applications, applied electrical devices, and I call it alphabet soup because it's all, TENS, NMES, HVPC, FES, IFC, all these different things. And then a bunch of other different names, microvolt, high volt, Russian stim. Some of those things refer to applications, others to types of equipment. None of them depend on clinical efficacy. So, can you set the parameters on an adjustable TENS unit to do muscle stim? Yes, you can. Can you set the parameters to do sensory stim? Yes, you can. So NMES usually doesn't refer to a particular device or a particular application. It usually it refers to neuromuscular electrical stim. High voltage pulsed current is usually a particular type of device that's used for wound care or other specific applications. FES, functional electrical stim, is usually something you're using the electrical stim in a particular way in order to improve neuromuscular function. So it could be a specific device, like a device that stimulates your tibialis anterior to get dorsiflexion when you're walking, or an electrical stim bike, or an electrical stim rowing machine, or something like that. Or it could just be how you're using another device for functional stim. So that's what I mean. These don't always mean one particular thing. IFC, interferential current, is usually used for pain management, and that is a specific device. So all of those, all those words and letters and names are only relevant if you're using a specific device for a specific thing. But most of the time, most things are adjustable. Am I going to use an IFC machine to do muscle stim? Probably not. Could I adjust the parameters to do that? Probably. So it's and some of it is just personal preference, what the therapist prefers or feels more comfortable with. So some people swear by Russian, some people swear by NMES for muscle stim, some people swear by TENS or swear by IFC for pain management. But really, it's what you're comfortable with, what devices you can configure the way you want them to get the results that you want. So it's better to kind of look at this with purpose-driven terminology. So these are our indications for electrical stim: pain management, sensory excitation. So it might be a component of motor relearning or pain control. A motor excitation for neuromotor retraining, strength or endurance enhancement. Electrical stim for wound healing. Electrical stim for transdermal medication transfer. So once you know the type of current required to evoke a particular physiological effect and the type of current generated by a given device, you can select the equipment that's best suited to accomplish your treatment goals. So it doesn't have to be one particular thing. Even though you might work with PT who always uses Russian stim for muscle stim, if you know the type of current that you want to evoke a particular physiological effect, you could use something else. So a continuous direct current stimulator. So the electrical device that we use for e-stim is called a stimulator. Is usually only used for iontophoresis, transdermal delivery of charged medications at a very low amplitude, 0 to 4 milliamps. There's no frequency because we don't have pulses, we don't have cycles. It's direct current. It's just always on, always one phase. There is a net charge or net that builds up underneath the electrodes because we're using it to drive the charged medication into the skin. So the stimulator could be like the little machine that's shown on the top, and you have specific electrodes that use that have reservoirs to put the medication in. Or it could be like this little device that's on the bottom, which is a 24-hour iontophoresis patch. It has a little battery in the middle, has a positive and negative pole. You put the medication on the proper pole. So if you're doing dexamethasone, it's negatively charged. You put it on the negative pole, and you put saline on the positive pole. And then you put the negative pole over the area you want to affect, and you apply it like a Band-Aid almost. The 24-hour iontophoresis patch is applied like a Band-Aid. And they leave it on for 24 hours and then they take it off. So lots of different devices are used for pain control and nerve and muscle stimulation. There are ones that are asymmetric, biphasic, balanced waveforms. Usually there's no net direct current component, no net charge with pain control and nerve and muscle stimulation. Pulsed currents, any pulse current with an adequate pulse charge can be used. Amplitudes from 0 to 100 milliamps usually on most machines, unless you're using high volt and then you get higher milliamps. Sometimes people with neuromuscular issues need high volt because they don't respond to that lower voltage. Short pulse durations from 20 to 500 microseconds to stimulate sensory or motor nerves. Variable frequency, so frequency is pulses per second or cycles per second. And modulation, so modulation is being able to modulate either the frequency or the amplitude in order to slow down the accommodation of the nerve cells. Um, you can use any of these current stimulators to stimulate sensory or motor responses. You can use them for pain management with the gating effect. You can use them for pain management with other effects that we'll talk about. You can use them for muscle strength augmentation, neuromuscular retraining, joint range of motion facilitation, or orthotic substitutes. So the lower picture here, the woman has an electric orthotic substitute that is stimulating wrist extension to counteract a flexion contracture. So all sorts of cool things out there, all sorts of cool devices. Obviously, that's an application specific device. So interferential current is one that you commonly see in the clinic. It's not usually in home units, although there are some home IFC units you can get now. Kind of interesting. But basically, you have two frequencies, a carrier frequency and a cross frequency. And so you basically the frequencies cross and the out of phase results in a beat frequency that's the difference between the two carrier frequencies. So 100 hertz or 100 pulses per second, cycle per second. It's the that blends the two frequencies and there's no net charge. So you get the same results from that as you do from a pulsatile current unit where you have 100 pulses per second. With interferential current, it is important to cross the channels, and we'll try some different setups in lab. With pulsatile current, you don't have to cross the channels. Interferential current, the advantage of it, the higher frequency current, is that it may penetrate more deeply. It hasn't been proven. It's not been demonstrated in a randomized controlled trial, but it's thought that it may penetrate more deeply and overcome skin electrode impedance, which is that resistance in biological tissues, with less discomfort. So that's the idea of IFC. It has not been proven, but that's what's thought might happen. It can be used for sensory or motor stimulation, usually in pain control. There's no difference in efficacy when you compare IFC to pulse currents such as NMES or TENS devices. So, like I said, it doesn't matter which device you use as long as you know what parameters you need to set to get the result that you want. And we'll try all sorts of different devices in the lab and see what you think. So Russian stim is an alternating current application where you're stimulating large muscles like quadriceps are commonly, quadriceps and tibialis anterior are probably the muscles you stim the most in physical therapy. Every once in a while, I'll stim somebody's gluteus medius or wrist extensors, but that's about it. You should know how to do those ones. But Russian stim gives a sort of a medium frequency stimulation. I don't know what they mean by medium, but it has a 2500 hertz AC carrier frequency. Do we care about that? No. It's a sine wave, just like IFC is. There's no net charge. The phase and pulse durations are between 200 and 400 microseconds, which will stimulate a motor nerve. That's our motor nerve range. And modulated bursts of 50 to 100 beats per second, which is the same as pulses per second or cycles per second. And so that's our frequency sufficient to form a tetanic muscle contraction. Some people say, and this again hasn't been proven in a randomized controlled trial, but it may generate a more powerful but comfortable muscle contraction. It's used for motor stimulation, edema reduction, and joint range of motion facilitation. Some people, everybody's different in how they feel these, because we're all different, right? Some people feel like Russian is more bitey, and the pulse current applications are smoother. Try them both and see what you think. So there are other types of stimulators that we are not going to use in lab, even though I'll bring a microcurrent stimulator just so you can try it out just for fun. But Some of them are subliminal. Microcurrent is a subsensory um, application. There's really been no efficacy demonstrated for pain management or muscle retraining. There's theoretical application for tissue healing. There has been some research that supports using it for things like insomnia and PTSD, interestingly enough. There was a really big study that was done through the VA in San Francisco using microcurrent for PTSD, and it was shown to be effective. So interesting. Transcranial electrical stimulation is not usually used in physical therapy. It's usually used in like a neurologist office type setting. And it is used for central nervous system stimulation. But the problem is, the reason we don't use it in PT is because you can't monitor central nervous system responses directly. And so there are some interesting applications that I've read about, but we don't actually do that. But just so you know, there's other stuff out there. So a minimum of two electrodes is needed to complete a circuit. In devices that do direct current, um, there will be a positive and a negative electrode, and they're often color coded. In unbalanced pulse tau current waveform generators, there'll be a cathode and an anode, or positive and negative, functionally, and they might be color coded, but it doesn't matter because there's no net charge. So when you have a balanced waveform generator, which is what we use, both electrode leads can be either because there's no net charge. It keeps switching back and forth between positive and negative, and so the color coding means nothing. So unless you're doing direct current, which the only direct current application we're going to do is iontophoresis, the color coding of the wires doesn't mean anything. So just bear that in mind. So electrodes, the ones that you see most commonly in the clinic are the hydrocolloid, self-adhesive, conductive, disposable. They used to be, they weren't used as much because when they first came out, they were relatively expensive. The reason they're used more now is because we're trying to do infection control. We don't want to share electrodes between people. And so those are the ones you see most commonly in the clinic, and those are what we will use in the lab. Each of you will have your own sets of electrodes, and you use them on you, and you don't use them on somebody else. Write your name on them. The silver chloride with conductive paste are usually used for electromyogram recording electrodes, and so you'll see those in a neurologist's office. They're carbon silicone with a conductive gel and a metal with sponge covering that's water soaked. Nobody uses those anymore except one PT that I know. He's old school, but you might see those. Some if you run into a PT who's old school, you might run into those. And the advantage of those is you can clean the metal in an autoclave. I don't know how you're cleaning the sponge, but the disposable ones are preferred for infection control. So electrodes have to be a good conductor. That makes sense, right? There needs to be uniform conductivity over the surface of the electrode, and they have to be malleable so they can shape themselves to the body contours that you're putting them on. So that's why those metal ones had to have a sponge because the sponge was the malleable surface. They have to be durable. They have to be hypoallergenic. They have to be easy to apply and take off. And they have to be disposable or sterilizable. So if they're not disposable or sterilizable, you can only use them once and then you have to throw them away. The disposable ones, you can actually use them several times as long as they remain in good condition before you have to then throw them away. So the current density, it's measured in milliamps per centimeter squared. It's the amount of current concentrated under an electrode. It should be an, not and, under an electrode. So basically, you want to use large electrodes for large muscles because you're using longer pulses and higher amplitudes usually, and small electrodes for small muscles. The depth of the electricity penetration into your tissues depends on how closely spaced the electrodes are. You don't want them so close that they're touching. You want them at least maybe 2 finger widths apart, if you want to think of it that way, about an inch apart, and or 2.5 centimeters if you like. The more closely spaced they are, the more superficial the stimulus is going to be. If there's more space between the electrodes, it will go deeper into the tissues. So consider how deep your tissues are and what other tissues are in the area when you consider your electrode placement. And we'll kind of consider electrode placement in the lab a lot too. So because there is we said that the surface of the electrode has to have uniform conductivity. If you have areas where the electrode is damaged, you can get big concentrations of current, and that can be a problem because your current density will be higher in the places that are intact. And the current density is higher in a smaller electrode than it is in a larger electrode. So non-uniformity of conductivity creates hot spots and risk burns. So that's what I mean when you make sure the electrode is in good condition. Non-uniformity can be due to the type of electrode or the site of the conductive media in the electrode, wear and tear, if you're reusing them, conformity to body surface area. So if you're putting a larger electrode on a smaller area and it's a more contoured area, it's harder to get it to stick all the way down. You want the electrode to be able to stick all the way down, have full contact, so you don't create hot spots. You might need conductive gel for certain electrodes. If you have uneven skin surface or variable skin surface, that creates non-uniformity and creates those hot spots. So the most dangerous setup probably is if one electrode falls off, well, then you don't have a circuit and it's not dangerous. If part of the electrode isn't stuck down, that's more dangerous because you have higher current density in the part that is stuck down. If you have a damaged electrode, that's more dangerous because you have hot spots. So always look at the condition of your electrodes and the condition of the patient's skin. So these are references for a whole bunch of stuff. And you can look through them at your leisure. And we'll go to lab, we'll try some of these things out, and then next week we'll come back and we'll talk in a lot more detail, specifically about electrical stim for pain management and electrical stim for muscle stim. Having practiced it in the lab, I think it'll make a lot more sense to you.